Head of Department of Pathology at Medanta, the Medicity, Gurgaon. He has also in the past, and it has also been very well received. So we are looking forward to a very lively discussion after the talks. So for all participants, the request is to put your questions in the Q&A box, and we will take up the questions at the end of both talks. So we'll start off with the first talk, which is by Dr. Prajakta Gupta.
So just we have to hold on for 1 or 2 minutes. There was a power failure, so I'm
Sure,
reconnecting the server. Sir.
sure.
We'll start with Dr. Prajakta, sir.
Good afternoon. Today we shall discuss ductal pathology with respect to liver transplant. So which are the different ductal pathologies following liver transplant? These are broadly categorized into large duct pathology and small duct pathology. So even when we get a biopsy, the first thing we would look at is whether we are looking at features of large duct obstruction or we are looking at a small bile duct pathology. So in large duct pathology, we have anastomotic or non-anastomotic large bile duct strictures, recurrence of large duct PSC following transplant. In small duct pathology, we have non-anastomotic small duct lesions, bile duct lesions of acute rejection, bile duct lesions seen in AIH PBC overlap, recurrence of small duct PSC, recurrence of PBC, ductopenic chronic rejection, vanishing bile duct syndrome as a presentation of drug-induced liver injury, and lesions of fibrosing cholestatic hepatitis C. Now coming to large bile duct pathology. Within this, we have broadly the anastomotic or non-anastomotic large bile duct strictures, recurrence of large duct PSC, and cholangitis. So histologically, what we would see within the portal tracts, like since the biopsy represents the peripheral liver parenchyma, so what we are going to see on the biopsy is the reflection of obstruction, large duct obstruction occurring closer to the hilum. So here we are going to see secondary changes like edematous portal tract with mixed inflammatory infiltrate, often with numerous neutrophils, bile ductular proliferation, feathery degeneration of hepatocytes, centrilobular canalicular cholestasis in the acute phase, cholangitis. So ascending cholangitis may develop and these lesions can be seen in the biopsy. And in long-standing cases, we would see portal fibrosis, which would eventually progress to biliary cirrhosis. Then bile lakes, bile infarcts, bile plugs, and cholestatic rosettes can be seen. We will have a look at all of these features, histological features. So what do we see here in this image? This is the main bile duct of this portal tract. We are seeing lot of ductular proliferation, too many proliferating ductules. We are seeing a mixed type of inflammatory infiltrate with presence of neutrophils, some lymphocytes, occasional eosinophils. And look at the portal tract. It is edematous. It looks pale and the structures look quite spaced out. That is because there is portal edema. So these are features of a large bile duct obstruction. These are the changes that we can see in the portal tracts on a biopsy. Now, what do we see here? Again, we are seeing ductular proliferation, some mixed inflammation, some cholestasis here. Some of these hepatocytes are appearing ballooned. What do we see here? Now, here is a cluster of hepatocytes which look pale. Here, this area. And this is feathery degeneration. So feathery degeneration is actually collate stasis. So collate crystals get deposited in the hepatocytes and they dissolve in processing, and hence we see these pale hepatocytes. So these are different than regular ballooning degeneration in that these are not degenerating hepatocytes, or they are not dying in hepatocytes, but they are hepatocytes filled with collate crystals and they are seen as clusters. So rest of the, as we can see here, the surrounding hepatocytes look all right. And suddenly we have this cluster which has a pale feathery appearance. So this is feathery degeneration. Here we can see canalicular cholestasis. You can see that the canaliculi are plugged with bile. And in the acute phase of large bile duct obstruction, this is one of the earliest features to show up. That is centrilobular canalicular cholestasis. Here we have a bile lake. So what are bile lakes? When there is in severe obstruction, usually long standing, then because of the back pressure, all this bile, it gets, it forms a lake or pool-like appearance in the hepatocellular parenchyma, that is in the lobular parenchyma. So this is free-lying bile in the lobular parenchyma. It is not within a bile duct or canaliculus. It is free-lying. And around that, we can see some inflammatory response. We may even see a few necrotic hepatocytes around them because of the pressure effect. Like here, we can see this bile lake and surrounding hepatocytes are getting necrosed. So this is called a bile infarct. So a bile lake can progress to a bile infarct. And these are bile plugs. Now, how is this different from the previous bile lake or bile infarct? Now, these are present within the bile ducts, ductules, and canaliculi. So they are enclosed within the biliary structures. So these are bile plugs. And what do we see here? These are within the canaliculi. This is canalicular cholestasis, but along with that, we can see that the surrounding hepatocytes are forming a ring-like appearance. That's also called as rosette. So these are cholestatic rosettes. These are called as cholestatic rosettes, where you have a bile plug inside surrounding by rosetting hepatocytes. And eventually all this can progress to fibrosis and cirrhosis. So these were all features of large bile duct obstruction. Now coming to small bile duct pathology. So when what are the different small bile duct pathologies? They are conditions which are going to affect the smaller ducts, more peripheral ducts. So we have non-anastomotic small duct lesions, bile duct lesions of acute rejection, autoimmune hepatitis PBC overlap, so bile duct lesions of AIH PBC overlap, recurrence of small duct PSC, recurrence of PBC, ductopenic chronic rejection, vanishing bile duct syndrome, acute cholangitis, fibrosing cholestatic hepatitis C. Now, how is this pathology going to be different than large bile duct obstruction? So there, what we are sampling is the peripheral liver. Hence, in large duct obstruction, the changes that we are going to see are predominantly the secondary changes and not the lesion itself, because the lesion would be closer to the hilum and the lesion would be seen radiologically. Whereas here, we are actually going to be sampling the lesion itself when we are talking about small bile duct pathologies. So what are the different histological features that we can see? So we can see duct inflammation, where the duct would show infiltration by lymphocytes. There can be duct injury, where there can be vacuolation of duct epithelial cells, and the uniform spacing of biliary nuclei would be lost. So they would be more irregularly spaced with vacuolation of the cells. Infiltration would be seen. Then in conditions like PBC, florid bile duct lesions can be seen. Now, what are florid bile duct lesions? Where we get periductal lymphoid aggregates, histiocytes, granulomas surrounding the bile ducts, in addition to features of duct injury and duct inflammation. And onion skin fibrosis can be seen in PSC lesions. Then in conditions like vanishing bile duct syndrome due to DILI or ductopenic chronic rejection, we would see ductopenia, where the bile duct itself is absent, and along with that, ductular proliferation is also absent in majority of the cases. Then again, in long-standing cases, we can see portal fibrosis. One thing to note is that histological cholestasis may or may not be seen. In fact, in many of the cases, we don't see histological cholestasis. So that doesn't rule out possibility of a ductal pathology. So let's have a look at the lesions. Now, what do we see here? Now, this is a bile duct, and we can see it being infiltrated by lymphocytes. So these are the bile duct nuclei here, the bigger ones, and these small dark ones here, they are the lymphocytes. We can also see that the portal tract is showing infiltration by lymphoid cells. So which all conditions can we get this pattern? We can get this in acute cell-mediated rejection as a component of the rejection, where we have portal inflammation, bile duct inflammation, and endothelitis. So this can be a component of cell-mediated rejection. We can see this in early changes of PBC, and it can also be seen as a component of autoimmune hepatitis PBC overlap, where we would see a more intense, here the portal inflammation is not that intense in this case. So it is less likely here, but I'm just saying that this kind of appearance can be seen in AIH PBC also. Now look at this bile duct. What do we see here? These are the nuclei of bile duct epithelial cells. They have lost the uniform spacing. They are more irregularly spaced with each other, and we can also see some vacuolation of the cytoplasm, the bile duct epithelial cytoplasm. Again here, surrounding portal tract is showing a modest inflammation, predominantly composed of lymphocytes. We can see an occasional eosinophil here, and an occasional plasma cell here. So this is a mixed type, predominantly lymphocytic portal inflammation with bile duct showing duct injury, features of duct injury, that is vacuolation, irregular spacing of nuclei. And we can also see some lymphocytes infiltrating the bile duct. So again, here we have the same DDs, whether we are looking at cell-mediated acute rejection or whether we are looking at AIH-PBC as a recurrence. So pure AIH recurrence can also show a few lymphocytes infiltrating the bile ducts, but not many such lesions. But few portal tracts may show this picture, and that does not entirely push it towards a PBC overlap unless we see more frequent affliction of the bile ducts, and the serology also should support the same. Now here is a florid bile duct lesion. Here this white space is the portal venule. Here in the center of this nodular infiltrate is a bile duct. Now this bile duct also shows infiltration by lymphocytes, irregular spacing of nuclei, and it is surrounded by a dense lymphoid infiltrate. The infiltrate has lymphocytes, many histiocytes. So the central part is showing a lot of histiocytes. There are lymphocytes. We can see some eosinophils. It's a mixed type of infiltrate and it is almost forming a nodular configuration. So this is a florid bile duct lesion. Now this kind of lesion would point towards PBC, primary biliary cirrhosis, and the earlier lesions of PBC. Now what do we see here? Here we are seeing onion skin fibrosis. Now onion skin fibrosis is classically seen in PSC, primary sclerosing cholangitis. In post-transplant patients, there can be recurrence of PSC. Also, we can see such lesions in non-anastomotic bile duct lesions. So these are basically, those are vascular lesions due to if during the anastomosis or in the due to non-anastomotic immunological causes, if the vascular supply, blood supply to the grafted liver is affected, then the first structures to get affected would be the bile duct epithelial cells, and after damage, they may eventually form these PSC-like lesions. So that is a DD for PSC, whether it's a recurrent PSC or it is a non-anastomotic bile duct lesion. So to call it a recurrent PSC, we should ideally have a history of PSC, proven PSC prior to transplant. Now, what do we see here? Where are the bile ducts? This is a portal venule. Again, a portal venule. This is an arteriole. And we simply cannot find the bile ducts here. Also, there is no ductular proliferation to go along with it. So what we are looking at is ductopenia. To confirm this, we would do a CK stain or a CK7 stain to highlight the bile ducts. So again, on doing these stains, we would find that portal tracts are not showing any bile ducts. And absence of bile ducts is permitted in 30% of portal tracts because the cut of the biopsy may not be passing through a portal, through a bile duct. So that is permitted in about 30% of portal tracts. If more than 30% of portal tracts are showing absence of bile ducts, then that is diagnosed as ductopenia. Now, where all do we get such ductopenia? Ductopenia can be seen either in vanishing bile duct syndrome due to drug-induced liver injury or in ductopenic chronic rejection. So how do we know which of the two? in cases of VBDS, vanishing bile duct, we would have a history, a preceding history of drug which is known to cause VBDS. And usually there will not be a history of recurrent acute rejection or late acute rejection in these cases. Whereas in cases of chronic rejection, we would have a history of late acute rejection or recurrent acute rejection in the past where it has been documented. So then that is a consequence of the rejection process. So history is important to differentiate between the two. Here we can see that this is a bile duct and it is showing dense, intense neutrophil rich infiltrate which is seen within the lumen as well as in the wall of this duct and permeating into the surrounding portal area. So this is acute cholangitis, also called as ascending cholangitis. Cholangitis can affect the larger ducts as well as it can ascend towards the smaller ducts and we may actually see the lesions. Now going through, just brushing through the individual biliary lesions, bile duct lesions. We have already covered these in detail during the previous class of cholestatic liver pathology, but we are just brushing through them in the context of duct pathology. So what are anastomotic bile duct complications? They present as bile leaks or usually in the early post-op period or bile duct strictures a little later on. A higher incidence would be seen in split liver transplants and in children due to the smaller size of bile ducts and their vascular supply. Histologically, we are going to see features of large bile duct obstruction. In the acute phase, we will see portal edema, bile ductular reaction. We may see neutrophilic infiltration with or without eosinophils and variable cholestasis. In the chronic phase, we would see periportal fibrosis and that may progress to biliary cirrhosis. So what is the role of liver biopsy here? Diagnosis, identifying it as a large duct obstructive lesion, determining the severity of the fibrosis, and ruling out other causes of graft dysfunction. So what would this look like on biopsy? It would look like a large duct obstruction. We will see features of large duct obstruction essentially. Non-anastomotic biliary complications. They are ischemic type of lesions as bile duct epithelial cells are prone to ischemic damage. So these are biliary lesions secondary to ischemia. And the underlying causes are hepatic artery thrombosis, hepatic artery stenosis, small for size grafts, reperfusion injury due to prolonged cold or warm ischemia, vascular sludging in the smaller capillaries, ABO incompatibility, antibody-mediated rejection. So any of these can cause secondary changes in the bile ducts. And they have two patterns, the early and the late. The early cases which present early on usually present as strictures of large bile ducts. And radiologically, they can be seen as either strictures or dilatation involving one or more large intrahepatic bile ducts, and the radiology can resemble PSC. They may develop secondary infection, lead to ascending cholangitis, abscess formation can also take place, and often retransplantation is required. The late complications are usually seen after a year of transplant, and they affect the peripheral smaller ducts usually. So in the late ones, we are more likely to see the actual lesions on biopsy, and we will see small bile duct pathology. They may appear like small duct PSC lesions. Histologically, non-anastomotic biliary complications, we would see features of biliary obstruction. If the larger ducts are affected, then we would see features of large duct obstruction. Small duct lesions would be patchy in distribution. Histological abnormalities in the biopsy may be minor, and we may see more severe abnormalities on radiology at the hilum, which is typical of large duct obstruction lesions. Findings overlapping with early stages of chronic rejection, like atrophic bile ducts, perivenular hepatocyte dropout, ballooning, cholestasis can be seen. Findings overlapping with PSC, such as fibro-obliterative lesions involving medium-sized ducts, disappearance of small interlobular ducts, ductular reaction, biliary fibrosis, bile lakes. All of these findings may overlap with those of PSC. Here we can see acute cholangitis. Now coming to chronic rejection. On histology, we would see loss of small bile ducts, that is ductopenia. Portal fibrosis can be seen. Cholestasis may or may not be seen. And usually there is absence of secondary biliary features such as bile ductular reaction. So ductopenia with absence of ductular proliferation and presence of fibrosis can be seen in chronic rejection. And similar findings can also be seen in VBDS. So correlation with history of recurrent or late acute rejection is important. And no drug history would be present. Now here is a biopsy showing mild fibrosis and presence of fibrosis, mild inflammation, absence of bile ducts, no ductular proliferation. Coming to vanishing bile duct syndrome as one of the patterns of drug-induced liver injury. We can see ductopenia, portal fibrosis, cholestasis, and again here also bile ductular reaction is usually absent. Correlation with history of associated drug and chronology of events is important. Here we can see absence of bile ducts, but portal fibrosis has not yet set in, which if it is left untreated, then fibrosis would develop eventually. Coming to recurrent PSC. Now, recurrent PSC and ischemic cholangitis, that is non-anastomotic bile duct lesions, they have very similar appearances radiologically and histologically. So to call it recurrent PSC, the criteria are presence of confirmed PSC before the transplant. Diagnosis should be more than 90 days after the transplant. So before that, we are going to give a higher possibility, higher preference to the possibility of non-anastomotic bile duct lesions. And characteristic strictures on cholangiography and fibro-obliterative lesions or fibrous cholangitis on histology. And there has to be absence of hepatic artery thrombosis, stenosis, chronic rejection, anastomotic strictures, non-anastomotic strictures before day 90 or ABO incompatibility. So if any of these is present, then again we are going to give preference to diagnosis of non-anastomotic bile duct lesion, that is ischemic cholangitis, over a diagnosis of PSC. So these stringent criteria have to be followed so that we do not overestimate recurrent PSC, as these lesions are going to be very similar to ischemic cholangitis. Now these are the lesions. We can see this onion skin fibrosis around the bile ducts. Thus there is bile duct inflammation. Now recurrent PBC. Now this usually recurs in the mild subclinical form, and there's usually no obvious impact on patient survival or graft survival. So here is a florid bile duct lesion of PBC. More commonly, we are going to see AIH PBC. And now, when we see AIH PBC overlap, a differential of differentiating between acute cell-mediated rejection and AIH PBC overlap often becomes a challenge, because in both conditions we are going to get intense portal inflammation. The inflammation may spread to the periportal location, that is interface zone, and there can be bile duct inflammation, lymphocytes infiltrating the bile ducts, bile duct injury. So both of these features can be seen in both AIH PBC as well as acute rejection, acute cell mediated rejection. So how do we differentiate? So we'll try to look for vascular lesions, that is endothelitis. So if we see a significant endothelitis, then it is easier in such cases where we are seeing significant endothelitis, and then we would lean towards a diagnosis of acute cell mediated rejection. Similarly, if we see a significant lobular infiltrate, a significant plasma cell rich infiltrate, so if there are a lot of really lot of plasma cells, and there is significant lobular component, lobular infiltrate, then it's easier to lean on the AIH PBC picture or diagnosis. But in cases where we are just seeing this portal inflammation, some interface, mixed infiltrate with just some plasma cells and bile duct lesions, then it becomes at times difficult to differentiate between the two. Serology, if it comes positive, then that helps, but it need not always come positive. So yeah, that is a gray area. There we would have to keep both DDs. Coming to cholestatic hepatitis B or cholestatic hepatitis C, also called as fibrosing cholestatic hepatitis. Here we would see portal, periportal sinusoidal fibrosis, portal fibrosis and periportal sinusoidal fibrosis, prominent ductular reaction, cholestasis, hepatocyte ballooning, bile duct injury may be seen in the biopsy. So how is it different from chronic rejection? In chronic rejection, we won't see a prominent ductular reaction. Ductopenia would be prominent. And again, viral loads have to be correlated. So here we would have very high viral loads supporting a diagnosis of viral hepatitis. And however, the incidence is now reduced due to use of antivirals. That's about bile duct or ductal pathology in the post-transplant setting. Thank you. Any questions are welcome.
Thank you very much. Good, very nice presentation by Dr. Prajakta on ductal pathologies. Now I request Dr. Dheeraj Gautam's presentation, and then we will take questions for both talks. Thank you. Ma'am and Dr. Dheeraj, please stay online.
Thank you, sir.
Yeah, good evening, everybody. Now, today it is my third lecture, and I will be speaking on pre-transplant compatibility test and testing algorithm. So, algorithm is very important here. So, introduction is HLA, that is human leukocyte antigen system, plays an important role in immune response, and HLA type helps in matching organ donor and recipient. So, outside the body, we take the serum of the patient and WBC of the recipient, and we do outside matching So after the transplant, it will not mismatch. The importance is to prevent organ rejection subsequently after transplant. Then it will minimize the immune response, and then it ensure better post-transplant outcome. Actually, typing techniques are, it can be done by serological typing or it can be done by molecular typing, and the latest is by next generation sequencing. Then what is the significance of HLA matching in liver transplant? Unlike kidneys, liver is less dependent on HLA matching. So we have more challenge in kidney rather than the liver. However, we have to do the cross match of the liver also. HLA mismatch can still contribute to long-term complication and importance. That's why the importance to test anti-HLA antibodies, and there is an impact of preformed antibodies on the liver graft survival. So we do the cross match testing, and the old method was CDC. So it evolved, the method has evolved. Initially, we have done by CDC, then by flow cytometry, and now we are doing with the Luminex, which is a HLA lead-based test. So HLA typing in liver transplant is important in high-risk patient, very important for the high-risk patient. Special consideration for the patient with autoimmune diseases, then HLA testing in sensitized patients, like who has had previous transplant, who had multiple blood transfusion previously, then recent innovation in molecular techniques enable role of NGS and personalized medicine. HLA system overview. So what is HLA? HLA is a group of 10 antigen, that is HLA-A, HLA-B, HLA-C, and HLA that is class 2 are HLA-DR, HLA-DP, and HLA-D2 antigen. So we take the blood samples of both the recipient and the donor. We take the serum of the patient and WBCs of the donor. Then we can do either by PCR technique, sequencing method, or by cross-matching technique with the Luminex. So now, with this introduction, we will start what is the context and what is the test algorithm of the cross matching. So context is this fact, all the factors are affecting the outcome of the graft, of outcome of the patient. Then pre-transplant compatibility tests are very important, and pre-transplant workup like HLA typing or cross match. HLA typing with respect to transplant of human organ act, HOTA. So whenever you are doing a transplant, it will go to the committee, and ultimately the district officer is also responsible for that. So we have to prove the kinship. So there are two criteria for cross matching. One is to prove the kinship, and second is the scientific, to avoid the rejection and further complication after the transplant. So there could be a direct cross match, or there could be a virtual cross match. Test algorithm is introduction. Why do we need the test algorithm? And what are the material and methods which study setting, inclusion criteria, decision making, and result demographic? So we will subsequently we will discuss all these things. So factor affecting the graft and patient's outcome in solid organ transplants are age of the donor. The more is the age, the less chances of the better outcome. Age of the recipient, the same applies with it. Body mass index, comorbidities like patient has diabetes, hypertension, or donor. Causes of the donor death, disease donor transplant is important for the disease donor transplant. Then cold ischemia time, also important, and especially important in disease donor transplant. what is the ABO blood group and pre-transplant compatibility between the recipient and the donor. So what is the pre-transplant compatibility testing is HLA typing of the recipient and the donor, patient specimen, we acquire it, then store it, and the review of the report, anti-HLA antibody screening of the patient, and antibody identification if indicated. So what is the pre-transplant workup? It is done on the guideline with the TOTA, that is live related donor transplant. HLA typing and confirmation of relationship, that is kinship, either you can do by cross match or YSTR or mitochondrial DNA or autosomal DNA. But the most common is cross match. Then pre-transplant cross match, it can be done by direct or by virtual. So what we do, we coated the anti-HLA antibodies in a machine, and we do the donor HLA typing. And in virtual, what we do, we write down the antibodies on the one page of the recipient, and we write down the donor HLA typing, and we match to each other. So that is called virtual cross match. So nowadays in the Western countries, this direct cross match is replaced by virtual because it is more easier to do. So what is the Organ Transplantation Act? Transplantation of Human Organ and Tissue Act. It came in 1994 to provide a system of removal, storage, and transplantation of human organ for therapeutic purposes and for the prevention of commercial dealing in human organ. No hospital, unless registered under this act, shall conduct or associated with or help in the removal, storage, and transplantation of any human organ. If near relative, spouse, children, siblings, parents need permission of the doctor in charge of the transplant center or donate his or her organ. But the criteria was very restricted initially, so they have extended the criteria, and there was an amendment in 2011 that allows swapping of organs and widened the donor pool by including grandparents and grandchildren in the list. Authorization committee established by the state, chaired by the CMO, district authorizes solid organ transplant. So in our center in Medanta, this is not coming, but which are the donors? So 29% are wives, 23% mothers, then 13% sisters. So this is the main pool of the donors, in which include especially the wife, grandmother, daughters, husband, brother, son. So the type of tests required to confirm the relationship between recipient or donor are usually, in 97% cases, it is done by HLA. And in 3% cases, it can be done by mitochondrial DNA or YSTR or autosomal. So this is the form which we authorize that for certification of the genetic relationship of living donor with recipient. So we have to prove that the kinship. So now we come to the cross match. So direct cross match can be done by the three methods. One is, which is the oldest, is complement dependent cytotoxicity cross match, called CBCXM, in which there is a patient serum and there is a donor lymphocyte, and this is non-HLA specific and has a poor sensitivity, and it is a cell-based cross match in which you lyse the WBCs and put the dye into it, and according to the color of the dye, you will see whether it is 1:2 or 1:4 or 1:8. Now it is where it was not very specific. So then came the flow cytometry cross-match, that is FCXM. It is cell-based cross-match in which the patient serum and donor lymphocytes are matched. It is non-HLA specific but very sensitive. Latest is, which everybody is doing now in good centers, are Luminex cross-match, which is sensitive and it is HLA specific, in which there is a bead, magnetic bead, on which we put the HLA antibodies and cross-match with the donor. So antibody screening, identification and virtual cross-match. It is based on HLA bead-based test, commonly called solid phase immunoassay. Anti-HLA antibody screening is antibody test in recipient, that is solid organ, are panel reactive antibodies, that is PRA, or it can be done by Luminex antibody screening. It is a 3-cell panel. So the answer is whether yes or no. So there is no reading in it. However, in Luminex single antigen bead, that is SLA or SAB, it's a 11-cell panel, which is most specific. So anti-HLA antibodies, if you do the anti-HLA antibodies, then if it is negative, you can straightforward go for the transplant. If it is a positive, then go for the donor non-specific antibodies. And if it is positive, then you have to do the other test. Then cross-match, virtual cross-match, in which anti-HLA antibodies identified by the Luminex single antigen, and on the other hand, there is a donor HLA typing of the donor is done, and virtual cross-match done on the paper. So this is virtual cross-match. So what is the compatibility test algorithm? So why we need the test algorithm? So since no single test, whether cell-based or HLA-based, bead-based, is 100% accurate and sensitive, laboratories therefore usually use testing algorithm for compatibility, which is a combination of 2 or more tests. Several test algorithms published from different parts of the world, named after city of their origin, like Basel, like Leiden, like Minnesota. So there's a protocol. So if you see, this is a Basel approach. So in which the virtual cross-match is done between HLA typing of the donor and Luminex scanning of the recipient. If there's a reading, if reading is less than 500 MFI, and if there's a no DSA, so there's a you have to omit the CDC cross-match and straightforward go for the standard triple therapy. If this is positive, more than 500 MFI, and DSA is high risk, then you do the cross-match, CDC cross-match. If it is a negative and there is a low level of HLA DSA, then you give the ATG, IVIG, and triple therapy. If it is a high level of HLA DSA, then there is a no transplant. It is a very high risk. Now, there is a lead-in approach also, in which there is screening of patient by ELISA and CDC. So there are 3 scenarios. If there is a no antibodies, PRA is 0 to 5, then no prospective cross-match, and you can directly go for the liver transplant. If it is patient is immunized and PRA is 5 to 84%, then determine specific UM by CDC and indication with the Luminex. Then if PRA is more equal and more than 85%, then use HLA matchmaker, use negative screening result, and if CDC is negative, then go for that. A CDC is positive, then UM. So compatibility test algorithm of the Minnesota approach. in which you do the solid phase assay. If it is negative and no HLA alloantibodies, then cross-matching testing to add to risk stratification. So there are three approaches, but we have to find our own approach. So we have studied to proceed for our approach is the prospective multicentric observation study, which was conducted at Transplant Immunology Laboratory of three large tertiary care hospitals in NCR, India, between March 29 to July 29, and the study employed screening tests, that is CTX, cross-match, flow cytometric cross-match, and HLA cross-match, and compared it with the individual or combination of tests with confirmatory HAI, that is solid B test, that is gold standard. Sensitivity and specificity of individual screening tests, that is CTX, flow cytometry, and HLA, and various combination of these screening assays. We have tried different combinations were calculated against a HAI test. Transplanted recipients were also followed up post-transplant by performing HAS at 3 and 6 month interval post-transplant. So this is a prospective multicentric studies. So decision making during the study period is we have done 3 tests. Then if there is no DSA, proceed for the transplant. If there is a DSA, basically this studies is done for the kidney as well as for the liver. So the pair kidney exchange program was initiated and seek another compatible donor. So results are a total of 100 cases were analyzed. Out of 100 cases, 69 were male and 31 are female. The average age is 41 plus minus 13. History of subtype was found in 46%, and out of 100 patients, 45 patients underwent transplant in 3 centers. So this is the result. There's a cell-based assay. CDC, which is sensitivity is low, 12%, but specificity is low, but sensitivity is 100%. HLA base is 92%, and so this is, and so what we found is the flow cytometry cross-match with HLA is 100% sensitive and 76% is specific. So this is the best scenario to do it. Advantage and limitation of cell-based and HLA-based assays are, so these are the CDC cross-match is less sensitive, and flow cytometry and HLA based is more sensitive. Specific CD is more specific. Non-HLA antibodies is there in HLA it was not there. Result criteria, the CDC is subjective while flow cytometry and HLA is objective. The cost is everything is low, so need for a separate algorithm in resources restricted setting like ours. In India, there was an urgent need for evolving an algorithm which is sensitive, specific, and employ HAI only for limited number of recipients who have a positive screening test result. Only 49% required reflex confirmatory HAI test. In our study, algorithm of 2 screening tests, that is flow cytometry and HLA based, which has a sensitivity of 100%, was found to be more appropriate. A specificity of 76.1% means that the suggested screening algorithm would detect few false positives, which would get easily resolved by performing SAB. Delhi approach, which this approach is called Delhi approach, is an inexpensive algorithm which can be replicated in almost all transplant immunological laboratory in India and country with resource restricted setting. So this is different setting algorithm. We suggested algorithm for pre-transplant compatibility is you do the flow cytometry cross match as well as the HLA based cross match. If both negative, it is low risk. No further testing is required and proceed for the transplant. If either or both are positive, that it is high risk, do for HAI. If no DSA, proceed for the transplant. If DSA, then paired exchange or disease transplant uh, should be done. Take home messages test algorithm comparison comprise of two and more tests should be done in sequence series to enhance the sensitivity of testing process. Center formulate an algorithm of these two tests, antibodies and cross-match category, to allow as many patients as possible to undergo transplant with no minimal risk of AMR. A recent multi-centric study established that a combination of two screening tests, HAS and flow cytometry base, is 100% sensitive. Thank you very much.
Thank you, Dr. Dheeraj. That was an excellent overview of HLA system and DSA. And it's a very rarely discussed topic in liver transplant circles, but you've covered it really well. Thank you very much. So there is one question by Dr. Sonia Agrawal for Dr. Prajakta. In case of a biliary stricture, which is MRCP proven, why is there sometimes no intrahepatic cholestasis on liver biopsy?
Okay. So first of all, the appearance of or the visualization of histological cholestasis versus non-visualization. So there are many cases of bile duct pathology where we don't see any histological cholestasis, and it need not always correlate with the biochemical status of cholestasis. And secondly, presence of cholestasis in a biopsy, on the other hand, that also is not going to push you towards a diagnosis of bile duct pathology. You are going to see cholestasis in many other conditions. You can see it just simply in sepsis, in any hepatocellular injury, acute hepatocellular injury, even in your chronic cirrhotic patients due to any etiology. So, presence of cholestasis in the biopsy is not going to make a diagnosis of bile duct pathology anyways, and its absence is not going to preclude. So, yeah, we are not
Okay.
going to base our diagnosis on either the presence or the absence of cholestasis.
And one question for Dr. Dheeraj is there a specific patient where you think that this evaluation needs to be done, or do you think that it's needed for all patients who undergo liver transplant?
So there are a few high risk patients also, and you do two flow cytometry as well as for the HLA. Okay, if they are negative and virtual is negative, then there is no need. If one is positive, like I presented the flow chart there, so you go by the flow chart, and if it is positive, then you have to do the DSA also.
Sure.
Thank you.
Okay. Any other questions by any participants? Please put them in the Q&A box. Dr. Sandhya has asked a question which is not related to this talk today, but she wants to know whether the certificate for the course can be obtained in absentia, or they have to come in person to the ISOT conference. So I think you can have it in absentia also. I will find out. So the way it is that it will work is that every participant who has attended a certain percentage of lectures, the attendance has been maintained by the ISOT office. So they will a certain percentage of attendance is required for you to get a certificate. Once it is there, then we will send you an email with details, and we'll probably offer you both options to attend it, to receive it in person in Ahmedabad or in absence also. So we'll send you the details in email very shortly for that.
Thank you.
So if there are no other questions, it's 7:30, perfectly well timed. Thank you very much, ma'am. Thank you very much.
Thank you. Thank you.
For
sir.
such a
Thank you
nice
for the
talk, and
opportunity.
we'll end the session now. Thanks a lot.
Thank you.
Very well done, Dr. Ravi.
Thank
It was
you.
a very good session, and we
Thank you.
concluded it. Thank you.
Thanks a lot.
Thank you.